Hello friends, this is Dr. Sameen Afzal Junejo from Hyderabad, Sindh, Pakistan. Today I will show you a video on Phacoemulsification and IOL implantation which was performed at our clinic, and it's a single-handed surgery. In this operation we will not need the assistance of the phaco chopper, and as the first step I am doing the anterior capsular axis with needle cystotome, and my approach is through surgical limbus 1 to 2 millimeters posterior to the anatomical corneal limbus. A round, regular, curvilinear axis is performed by means of a needle cystotome without using the trypan glue dye. This is a closed chamber anterior capsular axis. The intraocular pressure is still well formed. We need adequate intraocular pressure to proceed for the full thickness corneal two-step incision by means of a diamond keratome. 2.75 millimeter diamond keratome is used to create a two-step corneoascular incision. It is a full thickness incision which is made at the surgical limbus. There is a slight bleeding at the site of the incision, which is very favorable for the incisional wound to heal quickly after the surgery within 1 to 2 days. And now two side ports are made, one at 8 o'clock position and the other side port is created at 3 o'clock position by means of a diamond knife, 1.4 millimeter diamond knife. Two opposite side ports are created in order to facilitate the aspiration of the cortical matter, which is stuck up at 6 o'clock and 12 o'clock position, and the side ports are also very beneficial in order to maintain the intraocular temperature during phacoemulsification by continuous irrigation of the fluids from inside the eye. And the two side port incisions, opposite side port incisions, are also quite helpful in negating the astigmatism against the rule in elderly patients. And now, after injecting the viscoelastic solution during the corneal hydrodissection and hydrodelineation, and now we are doing the Phacoemulsification by means of a phaco handpiece and phaco tip, and superficial sculpting is performed. The nucleus is pulled under high vacuum from the bag, and the nucleus is brought forward at the interpupillary distance without needing the help of a side chopper. We are continuously moving the nucleus, its fragments, side by side, and removing the nuclear fragments out under high vacuum. And now the epinucleus is being removed by means of a phaco tip under high vacuum of 550 millimeters of mercury. The phaco power is 40% and the flow rate in this case is 38 milliliters per minute, and the nucleus is completely removed without needing the help of any phaco chopper, only with the phaco handpiece. Epinucleus is removed, viscoelastic substance is injected in order to lubricate the inside media, facilitate the aspiration of the cortical matter, and the viscoelastic solution is quite helpful in preventing the pupil posterior capsular rent during the irrigation and aspiration. Now the classical Simcoe cannula, which is the two-way irrigation and aspiration cannula, it is now used by means of a side port. We are trying to aspirate the cortical matter. Now we are using the main incisional approach in order to remove the cortical matter very slowly and gently, saving the posterior capsule is still intact. Cortical matter is removed, and now we are going to inject the OVD dispersive prior to go for the intraocular lens implantation. Our main effort is to use least minimum phaco energy in order to save the corneal endothelium going into the corneal opacities in future. And now the hydrophobic foldable yellow IQ lens is being implanted by means of the injector exactly into the bag. The intraocular lens is slightly rotated and the haptics are brought at the horizontal positions beneath the 3 o'clock and 8 o'clock side ports. And this way the lens is very much positively seated, fixed into the bag. And now we are removing the viscoelastic solution. This is very important to remove the viscoelastic solution to avoid postoperative transient rise of intraocular pressure, and also to avoid the cellular reaction postoperatively, and we also try to avoid the refractive surprise when the viscoelastic solution is trapped in between the intraocular lens and the posterior capsule. So the removal of the viscoelastic solution in the end is very important. Thank you very much.